Welcome everyone to the fifth of the Sunday Conversations with Mass ME, presented by the Massachusetts ME/CFS and FM Association. The topic today is fibromyalgia. My name is Pat Woods. I'm a volunteer, caregiver, and a board member with Mass ME/CFS. I am delighted to introduce our speaker today, a colleague with whom I recently had the opportunity to work closely with as he initiated one of the first drug studies in the Boston area for COVID. Dr. Paul Monach is chief of the rheumatology section at the VA Boston Healthcare System and an associate professor at Harvard Medical School. He received his MD and PhD in immunology from the University of Chicago and completed his residency and rheumatology fellowship at Brigham and Women's Hospital. In 2007, he joined the faculty at Boston University to focus on clinical care and clinical and translational research in vasculitis. In 2014, he became chief of the rheumatology section at the VA, focused on clinical care of patients with vasculitis and mentoring junior faculty and managing clinical trials. He moved to the VA full-time at the end of 2021 in order to join the cooperative studies programs where I also work at the VA. Today, we'll also hear stories from two patients, Elizabeth and Vicky. Dr. Monach, thank you so much for giving us your time this afternoon. And now I'll hand it over to you, Paul.
Okay, thanks a lot for the invitation, Pat. Next slide, please. My disclosures are related to my work in vasculitis, a very, very different group of diseases, but one that also requires very close follow-up and a lot of attention to individual patients' needs. Next slide. Next. Sorry, I have multi-part slides. The key feature of, that's why I say a definition of sorts of fibromyalgia, because this has evolved over time, but the key feature is chronic widespread pain. It's obviously not an objective thing, something you see on any imaging study or lab test. Originally, there was some focus on shouldn't be regional pain, but then sometimes people had fibromyalgia, but also had osteoarthritis of the knees were being excluded. So you certainly can have both. Next, please. And then there are symptoms that support the diagnosis, and I have a lot of words here for a reason. So the first is almost everyone has fatigue, but most people probably don't meet the fatigue for ME. Even more, including my own patients, I must admit, don't get asked the questions to really find out. But there's a frequent overlap with irritable bowel syndrome, but people can have symptoms whether they meet the criteria or not. Everybody with fibromyalgia almost have some sort of sleep disorder, but sometimes it's named, sometimes it's just non-restorative sleep. Subjective cognitive problems, regardless of whether those will show up in testing. There's a condition that isn't very well understood called interstitial cystitis of the bladder, which causes chronic pelvic or bladder region pain. Headaches, which could be migraines, could be TMJ pain. And then what I think is really more of a growing area of interest is paresthesia. Sorry, this is also something for an MD audience as well, but I know this is a very well-informed audience I'm speaking to here, which just means numbness and tingling without necessarily sensory loss, and neuropathic pain, which is different from the type of pain you get with joints, muscles, and tendons. And that could be with a condition called small fiber neuropathy, which has only been recognized probably in the last 20 years, and probably other neurologic conditions that haven't been recognized. Next slide. So I'm not going to dive too much into the competing criteria, but going over them quickly is actually informative. So next, please. There's been a series of criteria from my own professional society, the American College of Rheumatology, and starting in 1990 was the first set, and it was notable for requiring counting tender points on an exam of a patient. And this is still something that people think of, and it has maybe some value, but isn't necessary for the diagnosis. And I'm not going to go over where exactly those points are. You can easily find them online, and I think I have a chart that shows generally where they are, but it's at various points throughout the body, in the extremities and more near the neck and lower back. Next, please. So there was an effort starting about 10 years ago to try to refine this diagnosis and make it possible for people in for patients themselves and people in primary care and other specialties to make the diagnosis without really knowing exactly how to examine tender points. Next, please. And then a separate group, and this is not in rheumatology, I think that's something for pain taxonomy is the second abbreviation. It's part of a larger initiative where they put things into 5 dimensions. I'm going to go through this just because I think it's informative, not because I use it in practice. Next, please. And there's some disagreement about this, but I've seen this number quoted a couple times of 2 to 4% of the overall population being affected. Next. So the reason I show this here, the ACR criteria from 2016, is it gives some sense of locations, but also is as good as anything for saying, does this patient, do you personally have fibromyalgia or not? And the fact that it can fit on one piece of paper is good. And I don't know of research being done in this area, but I can imagine what PRO stands for is patient-reported outcomes. This is appearing more and more in clinical trials. The FDA wants to see patient-reported outcomes or approving new drugs. And I got to believe this is empowering for patients. But you can see at the top that there are 5 different general body regions, and kind of like I told you, the legs, arms, neck, upper and lower back. But then also the 3 areas that are focused on, actually, I guess it's 6 now: fatigue, sleep problems, cognitive symptoms, headaches, pain in the abdomen or in the pelvis, and depression. Those aren't needed necessarily for diagnosis, but they kind of raise your suspicion. And criteria are never sort of a yes/no thing. So there are a lot of, and having the criteria also tends to make things a yes/no, and that's not how medicine is, and isn't how life is. So next, please. Yeah, so I put this up here because it gives a different way of looking at it that I think is informative. Next. They also divide the body into regions and say pretty much you have to have a certain number of them, but not necessarily all of them. They include fatigue and sleep as being essential for making the diagnosis. The tenderness on exam, etc. These are things that sort of support, increase your suspicion that that's what you're dealing with. The reason this is all important is because of, trying to make what we call a differential diagnosis, separating out fibromyalgia from other things that you might be thinking of. Next. And so similarly, these are things that people would say, well, they aren't part of fibromyalgia, but they often go along with it. Next. It's, these don't help you make a diagnosis, but they sort of show how important it is for patients, the consequences. Next. And then this is thinking of risk factors and protective factors, which I'll go into in a little bit more detail, though I don't know the primary literature. Next. So the term orphan disease, just so you know, I know from vasculitis that it refers to diseases that are rare enough that there hasn't been a lot of scientific study, so there are not a lot of FDA-approved drugs, and they have a better mechanism, easier mechanism to get approval for them or to get off-label use for drugs that are rare. Well, this is an orphan disease because for a different reason. So who manages fibromyalgia, I would say, in different places, and it's partly regional, it's partly just even less than that, what hospital you happen to go to, whether it's primary care, pain management, rheumatology, or neurology. And then the next is the same list, and it depends on who you ask. And the next bullet point is the key point of who loses out, and I don't think I even need to answer that. So I just want to take a minute to talk about how fibromyalgia is perceived among rheumatologists, and it's really not pretty. Next. So a lot of experts in fibromyalgia are rheumatologists. Some journals publish some of the most important articles on fibromyalgia, although mostly those are in pain journals, but some refuse to do so. And my own professional, I shouldn't say my own professional society, that's a little bit different, but the people who conduct the credentialing board exams don't even include it on the exam. So they say, you don't really need to know about fibromyalgia in order to be a board certified rheumatologist. So that's sort of a passive aggressive way of saying this isn't part of our specialty. Next. Some opinions have been stated. Someone I know who's a former ACR president said we need to get fibromyalgia patients out of our clinics, and some people cheered when he said that, and some other people were pretty, pushed back. Next. And Yeah, I mean, this is an example of somebody giving a presentation, had the title, it said the pathology of fibromyalgia, and then the rest of the slide was blank, and that was it, which isn't very respectful to say the least, even though there was not thought there'd be patients there. So the one thing you get as a point of agreement among rheumatologists, and this is more for, as a doctor thing, but you sort of take a look under the hood and see where this comes from, is most rheumatologists feel like I get to take, decide what my role is, but you don't. And I don't mean the patient, I mean the other doctors. But of course, that what often happens is that the patient doesn't get good care. Next. Something we should agree on, which I think is fairly obvious, but I think can get missed as people argue with each other, is that patients with fibromyalgia are genuinely suffering. That is obvious to this group. Isn't always obvious to everybody, and I'll come back to that. And all of the things that are mentioned here result in reduced quality of life, and there are plenty of objective ways of knowing that for patients with fibromyalgia. Next. So what are the causes a little bit? So it's thought to be a disorder of pain processing in the central nervous system. And I'll show you some diagrams with the peripheral nervous system with what's called central sensitization. This is generally agreed upon. It doesn't mean things aren't going to move. It's sort of, we now think this, but I have not seen contrary opinions. The understanding will evolve, but I think this paradigm, it will be more understanding within this paradigm rather than switching it. Next. And then next, the reason I use the term risk factors, is that I think I didn't draw a picture here, but I think there are things that get you to fibromyalgia that are actually quite different from each other. And it is called, when I abbreviate it as FMS, that's not just to keep it short, it's fibromyalgia syndrome. So it is an end point of very similar symptoms that can come from very different directions. One study I think was very interesting is they took healthy young people and didn't let them exercise and sleep deprive them. I don't know how severely. And supposedly 1 in 6 of them developed enough symptoms to meet the diagnostic criteria for fibromyalgia. And then that went away when they were allowed to exercise and sleep again. Also, the tender points in fibromyalgia, this has been actually shown in studies as well, are relatively annoying and tender in most people. So, the side of the elbow, the front of the shoulder where the coracoid process is, you push there and it hurts more there than it does in other soft tissues of the body. And pretty much it just means patients with fibromyalgia will feel pain there before, say, I will. And so hyperalgesia is a term that just means greater sensitivity to pain but there's still a stimulus. Allodynia is a term that just means that even just touch in an area is painful. Next. So this is a basic diagram that actually really exceeds my knowledge until I look at it, of how pain is processed. Next, we just have something that is added. So this is a nerve ending in the tissues, and that includes not just the tissues in the limbs and the skin and muscles and everything between them, but also the internal organs. And they go first to the spinal cord. That's what the bottom is. It's a cross section of the spinal cord. And afferent neuron means a nerve that is coming in. Efferent neuron means one that is going away. And so it goes, going up the slide means going up the spinal cord to the brain. So that middle section there is the midbrain, some of the most primitive, but most evolutionarily primitive parts of the brain, but very important. There are a lot of switching stations where neurons connect with each other and important regulation occurs. And so pain also goes up to the thalamus. People who've had strokes in the thalamus can have a terrible chronic pain syndrome, and it interacts with the higher areas of the cerebral cortex in pretty complicated ways. But you can also see that coming down from the brain with the perception of pain are other things that regulate how pain is processed and perceived. Next. Okay, so I'm going to show, not immediately, but soon, a little picture of some cellular interactions that occur at this area where its regulation can get screwed up, because what says descending modulation there, I don't know if you can see my little, probably not, my cursor, is that sensitivity to pain, to a pain signal being transmitted at this area, can be either increased or decreased at this location, but also at others. Next. So a lot can happen in the brain, as you can imagine. I think this is probably why fibromyalgia is a syndrome. and is associated with anxiety and depression and with sleep, but also with other things and with multiple sclerosis. Next. So a lot happens here to try to regulate the perception of pain, because pain is adaptive. It's important to be able to escape from painful stimuli. But it also is really bad for you if you perceive normal life as painful, which is a way, I think still an appropriate way to describe fibromyalgia in lay terms, is that the day's normal activities, and whether it's bumping into things, resting on a surface, etc., are perceived as painful instead of just sort of mild pressure. And so there are different points at which the neurons coming up connect in the midbrain and then come back down that are supposed to sum up to a feedback mechanism that reduces the sensation of pain if that stimulus continues, but it doesn't always work that way. Next. This is just some typical sort of arrows and colored circles that we use in medical journals to describe what happens in this case at a synapse, where pain conducting neurons, and actually there are neurons that are specifically for the purpose only of conducting painful stimuli. They aren't the same ones that describe sensation, pressure, vibration, etc. And so the afferent neuron is the one at the top. This is a synapse where it releases neurotransmitters that are the ways that nerve endings communicate with each other. They are perceived by receptors on the efferent side and at the bottom, and things happen inside the neuron that tell it to either send a signal or stop sending a signal. And there are cells nearby that influence how this occurs. And in particular, these are called glial cells, are pretty much anything in the central nervous system that isn't a neuron. But in this case, a lot of them are microglia, which are actually very specialized white blood cells. And so some of the things they secrete are not just specific to the nervous system, but are inflammatory. And that's why some people would refer to this as having an inflammatory component. And that's sort of a little bit of semantic difference, but it's something that we need to keep in mind as we think about mechanisms. Next. And so I'm going to show here a few different ways in which there can be dysfunction that leads to chronic pain. Next. So one of them, I'll start on the left with the nerve ending in the tissue, is that simply having peripheral neuropathy can lead to abnormal signals that just fire up this entire circuit in the wrong way. And an example I often give to people of independent of peripheral neuropathy, which I see a lot of because that's a consequence of vasculitis, is that, and we see this at the VA, amputees often have what's referred to as phantom limb pain. So after the limb is gone, it can become extremely painful because of the body trying to perceive a signal of a limb that is no longer there. And they actually take steps during amputations to try to prevent this from happening. I showed you if you move over to the bottom in the middle, you can see what I just showed there, that there's dysfunction. There's definitely dysfunction at this initial synapse, which plays a role in creating the central sensitization. Farther up, without going into details, which I frankly don't even know, you can see that there are a lot of opportunities to have problems. And not all chronic pain states are necessarily fibromyalgia. So I mentioned the phantom limb pain or a peripheral neuropathy, but people with chronic back pain a lot of times are regarded as developing a central sensitization, even if they don't develop overall body pain. As you probably know better than I do, people with ME/CFS can develop chronic pain that doesn't meet criteria for fibromyalgia, and also vice versa with the fatigue. We see a lot of PTSD at the VA. I've been told by PTSD experts that a lot of something like 40% of their patients have chronic pain, but a lot of them don't meet the criteria for fibromyalgia. So it's complicated, especially when you get up to the side of the brain. Next. So the big caveat here is that I'm not an expert in the field. I think I'm more knowledgeable about and interested in fibromyalgia than most rheumatologists are, but that's not really saying that much. I did review a fair amount for this talk, but I say the literature is vast. I do have a reference at the end that has over 600 references in it. And for things like neuroimaging, for example, neuroanatomy wasn't my best topic in medical school. The lab-based studies, I think, are very interesting, but one of the most important things is the conclusion at the bottom, which is that most studies have found differences comparing people with fibromyalgia and controls, which picking controls for studies like this isn't always easy. How do you balance by age and sex? That's usually relatively simple, but other medical problems, what medications you're on, that can be trickier. But there are different ways that people do controlled studies of, for example, responses to pain. And so there, believe it or not, are things that measure pressure and how much you push on somebody. And then when somebody says, stop, that hurts, then you look at how many pounds per square inch it was. Repetitive painful stimuli is different from just a single time thing. Sleep, there are particular sleep disorders that can be studied, but a lot of times people just have non-restorative sleep without any obvious abnormalities. Cognition, there are neuropsych tests. Neuroimaging is probably the most complicated and extensive. And I think what's important here is that these studies don't always agree with each other. So we're not really yet at a consensus, okay, this is what happens. There's some neat studies that can be done that have not made their way to the clinic called functional brain connectivity imaging and functional MRI spectroscopy. I didn't put there. Autonomic testing is something that we need more of in clinical medicine in general. I think it hasn't been, I think objective autonomic nervous system dysfunction is under-recognized in part because we can't measure it. Unlike, I don't know if any of you have had the pleasure of having an electromyogram or EMG, where electric shocks are put through your nerves to see if they are conducting electricity properly. We haven't had anything equivalent to that really, and it's becoming more and more available finally. But a lot of places, all they do is tilt table testing to show that many people have abnormal increase in heart rate with changes in posture, which is just an aggravation of a normal reflex. People who have Raynaud's phenomenon, that is associated with autoimmune diseases, but it's also really sort of an exaggerated normal reflex. Excessive sweating is another. But we're supposedly getting better at doing this testing, and I think it's going to be informative about this this condition and the diseases it's associated with. And then biomarkers, these are not yet in clinical use, and they probably never will be for cerebrospinal fluid just because it's an invasive procedure. But people have looked at variation in neurotransmitters and with function of that HPA, sorry, is hypothalamic pituitary axis, and in particular, going further to the adrenal gland and the role of cortisol in its regulation, which again, haven't come to any broad conclusions. Cytokines is a term for proteins that signal between or to white blood cells. So something I have to think about a lot in my practice and in my research, but in a different setting. And some studies will find differences and some won't. I should say, particularly to this audience, there has been less study of, and I think even to the extent there's been study of, less found in fibromyalgia to suggest immune system activation, inflammation, than there is in ME/CFS, quite a bit less. So there is less of a strong association, but it probably applies to some patients. Some patients will show a sign of inflammation, and some maybe they have something different. Next. So here's some of the risk factors. Some of these, we use the term modifiable and non-modifiable. So genetics, non-modifiable. A genetic risk score indicates that a disease is thought to have numerous common variants in the genome, things that many of us have, each of which confers a very small risk. And then you can add those up or multiply them and get a general genetic risk score. And this suggests about 25% heritability. That actually isn't a lot. So it sounds like a lot, but it really isn't. I don't know the numbers for identical and non-identical twins, which is sort of the hardest and most old-fashioned, but it's the most solid way of doing it. But notice that's also for, for onset at an early age. And that's the easiest place to see genetic risk factors for complex diseases. Next. Female sex, so this depends. It used to be said 90% of patients. Now the number is given at 70% at most. And it is thought it's lower in real practice than in clinical trials. And whether it's really a different condition or perceived differently in men and women is not really clear. One question I got in advance of this was whether there is a differential genetics in men and women. The short answer is I don't know, but most studies aren't done that way, to be honest. They either exclude the Y chromosome and just put men and women together, or they only do one. So I'm not aware of both things being done, but maybe they have been. There's been at least more study of fibromyalgia in men, my understanding, in the past few years. Next. And so autoimmune inflammatory diseases, this is what I do. Lupus, Sjogren's syndrome, which is a disease of salivary and tear-forming glands and other glandular tissues, probably have the highest. They're in the range of up to 30% of patients will have fibromyalgia, meet criteria for it. Maybe a little less in rheumatoid arthritis. I feel like we see it a little more commonly in psoriatic arthritis than others, but I don't know for sure. But importantly, and this was a surprise, very disappointing surprise to patients, is that the fibromyalgia symptoms typically don't go away, even when everyone agrees that the control of the arthritis is good. Next. And then other medical conditions is kind of a grab bag. So let's go on. So potentially modifiable. Next. Anxiety and depression. I wish they were more easily modifiable than they are, but there's potential. And I mentioned this for a reason. This is a semantic point. Is it a risk factor, or is it sort of a comorbid condition? I think the important thing is the third point there, that the parallel treatment of pain and the psychiatric illness they're synergistic. So one doesn't cure the other. And the idea that was pretty common when I trained in rheumatology 20 years ago, that basically fibromyalgia is psychosomatic. It's a sign of people internalizing their anxiety and especially depression, not sleeping well, and therefore you get fibromyalgia. And if you could just treat that, they'd get better. It doesn't work that way. And treating, but however, and this is sort of, there's, in a sense, it's kind of obvious, but it's good to actually know that treating depression doesn't cure chronic pain, but it helps. Treating chronic pain doesn't cure depression, but it helps. And so doing the two together helps both. And that's actually some really nice quality research. I'll put in a plug for the VA at the VA in Indianapolis. The history of abuse, I don't know the primary literature on this. I think there's enough study to believe that it is true. I've heard numbers of as high as 10% of people reporting that, but I don't know the range. And again, this is primarily coming from people with people who've gone to academic medical centers. But it is also often reported by patients that new stresses in life will lead to exacerbations of fibromyalgia. And that is not terribly surprising. I've seen that myself among my patients. Next. Sleep disturbance, as I mentioned, even people who don't have a history of chronic pain can develop fibromyalgia temporarily if they're deprived of sleep. Again, I've also heard this from patients, I've seen it in patients, in a couple of young women shortly after they had babies. And that's why I say there probably is a cause and effect relationship. I wish sleep problems were more easily treatable. Next. Low physical activity. This is a key point I've been instructed that is different from ME/CFS. Cause and effect is difficult to determine, but there are actually multiple randomized trials showing that different forms of physical activity are beneficial. And that, my understanding is quite different from ME/CFS. Next. And excess weight, again, it's hard to say if somebody is unable to be active because they hurt and are extremely tired all the time. It's hard to not gain weight. Next slide. So this is a term I just made up, and it all that means is there's a rheumatologic disease with the old-fashioned name polymyalgia rheumatica that is an inflammatory disease of older people. But I'm going to put this into two categories. So there are conditions that can mimic fibromyalgia, and I think is why, honestly, any rheumatologist should see patients and make sure nothing is being missed. And so a combination of regional problems, as I put up at the top there. Spondyloarthropathy is a mouthful, but for rheumatologists, that means a disease called ankylosing spondylitis, and related diseases, psoriatic arthritis, reactive arthritis. PMR is an inflammatory disease of the hip region and shoulder region, and often other places. Metabolic myopathies are actually diseases of muscle that cause muscle metabolism to be screwed up, so that in particular anything other than very short-term exercise becomes quite painful. Myositis is a rare inflammatory disease of muscle, but it's usually weakness rather than pain, but not always. My understanding is a lot of patients with multiple sclerosis have chronic widespread pain. Vasculitis is a disease that I take care of, but occasionally it sort of sneaks up on you without having an obvious location. And drug reactions have actually caused this with a disease called a drug called multiple times with a disease called drug called mycophenolate or Cellcept, which I had to give people for vasculitis or lupus. It's not listed in the product insert, just as back pain. Next. And then I mentioned that lupus, Sjogren's syndrome, and to a lesser extent, rheumatoid arthritis, fibromyalgia is particularly common. It used to be said so about hepatitis C. I'm not sure anymore. Next. So this is a more or less accurate set of overlaps with Venn diagrams for fibromyalgia being 2 to 6, 2 to 4% of the total population. And if you put together the numbers of percentages of people who have RA, lupus, Sjogren's, MS, and that not all of them have fibromyalgia-like symptoms, that's a relatively small percentage. So it doesn't tell us what other autoimmune diseases we might be missing, but I'd say that it is not a fundamentally autoimmune condition. But there's probably a lot more overlap with things that we don't know about. But does it add up to 1%? I'm not sure. That would be more my guess. I doubt that we're missing more than we have. Next. Like I said, I'm not going to try to put a Venn diagram of all these conditions. I've very roughly put the sizes of the circles based on how common the disease is considered to be in the literature. I doubt that those are accurate. I've mentioned some of this before, irritable bowel syndrome. I'm not going to talk in detail about small fiber neuropathy. There's an expert in the Boston area whom you may know of, Anna Louisa Oaklander at MGH, really educated rheumatologists in the region about this condition. But a lot of people will meet criteria for one or the other of these things. And one thing I mentioned, because I know it comes up, how can you tell if you have CFS-ME, whether you have fibromyalgia or not? You can certainly do the criteria, but I'll just highlight one way in which they might be different in some patients is the response to exercise, a good thing or a bad thing, and also the onset, if the onset is associated with an infection. The percentage that is quoted for onset shortly after an infection with people who meet criteria for fibromyalgia is there, but it's something like 10%, as opposed to much, much higher than that for ME/CFS. Next. So making the diagnosis, the questionnaire I think is a pretty good start, but you listen to the patient. I think an exam helps. If someone has no muscle tenderness at all, that reduces the risk, but I don't necessarily count tender points. I usually try to separate out. I think this is coming up next. The next point. Yeah, so I refer to joint-specific pain. If someone, even if they don't have swollen joints, if it's really only specific to joints, if it comes with the use of the muscles, but I'm not pushing on them, this is just something we can learn to do in the exam. That goes more toward a focal muscle or tendon sprain or strain. And then, if patients have things in other organ systems that lead us down a different path, that there is a different disease. And then I have a slide on labs. Next. So there's a big difference of opinion for what you should send when working up someone with fibromyalgia. And a lot of at least the older rheumatologists that I've worked with said, if I see a patient, they have fibromyalgia, I don't send any labs. It does more harm than good if you chase things. I disagree a little bit. Next. I think that so the ESR and the CRP are blood tests, non-specific blood tests for inflammation. I send them because there are an awful lot of people who don't have a named disease in whom those will be high. And they sort of hint that you should really keep your eyes open, whether you treat people differently. You don't necessarily give people immune suppressive drugs on that basis, but you just stay more alert to the possibility that there's an underlying inflammatory disease. And I've seen patients I've followed for for a long period of time thought to have maybe osteoarthritis of the knee and fibromyalgia. And then, suddenly they say, oh, it's happening again, just like it did 20 years ago. And lo and behold, they have psoriatic arthritis. CK is something I often send. That's an enzyme made in muscle that spills out into the blood. And if it's really high, that might be a sign of an actual muscle disorder, but that's sort of a low yield phenomenon to check that. Vitamin D, often people have it checked. Magnesium is something we're likely to be deficient in our diet unless we eat a lot of dark green vegetables. But I usually don't screen necessarily for a broad screen of all internal organ system. That's what all these other tests are for. Almost everybody has already had a TSH, that's a thyroid test. That's sort of an obvious thing to do in anyone who has chronic fatigue or weight gain, but it usually ends up being normal. I often send another thyroid test called T4, just on the small chance that there's a pituitary problem instead of thyroid. Next. What I tell other doctors, though, is I wouldn't send labs related to autoimmunity unless you have a particular reason to suspect a particular disease. Because you can really, especially with the ANA test, you can go down a rabbit hole here. That a low titer, meaning a low concentration antibody to ANA is called anti-nuclear antigen. It's a very old-fashioned test. It's useful when it's high and other stuff is going on for patients with lupus or Sjogren's syndrome. But otherwise, it can be a false positive that sends you in the wrong direction. Next. I want to get to a little bit about treatment. Next. So non-pharmacologic approaches, I'm not sure education has been put to the test in terms of randomized trials, but I think starting with the fact that I'm going to do my best to help you, hopefully your doctor says that, I'm going to do my best to help you, but you're also going to have to live with it. And that's what leads to better function. And it is reported by experts in this field that actually helps. And, being given the realistic goal along with, I'm going to walk with you to try to help this happen is a good, what I want to say, is a good exercise, as it were. Exercise itself is, although there have been individual trials of individual modalities, it's just sort of common sense that you should individualize it to the patient. You can't tell everyone that they should go swimming. Gradually increasing the intensity is widely recommended, otherwise people won't be able to do it. And then the other thing I mentioned, I'm wondering myself, just as I learn more about ME/CFS, if I should do a little more screening for that, because maybe I shouldn't be pushing exercise in someone with that condition. People talk about aerobic exercise within rheumatology, but it's thought just whatever you can do. Get your body used to exercising, get your muscles used to the pain of normal activity. And it is thought, because it's thought sort of a no pain, no gain kind of thing, you get used to, your body gets used to that discomfort. Cognitive behavioral therapy is the psychological intervention that has been tested multiple times. It has some of the highest grade scientific evidence for benefit. Having the highest grade evidence doesn't mean it has the highest magnitude of benefit. And so all of these things can help a little bit. Occasionally, it's incredibly gratifying when you tell a patient to go to the gym or to do something related to their sleep or do cognitive behavioral therapy, and they come back and say, I don't think I need to come back, I'm so much better. But that doesn't happen very often. And so it's often a combination of little things. And you try something for a while, and if it doesn't work, you stop doing it. Sleep hygiene, easier said than done. You can't write a prescription for someone to have more sound sleep. But I have a low threshold for sending someone, if I'm suspicious for sleep apnea in particular, to send them. Next. So there are drugs for which there's good evidence. We reach for these pretty quickly, but probably because we're not so good at explaining the other stuff very well. Amitriptyline is a very old-fashioned, what's called a tricyclic antidepressant. Cyclobenzaprine is marketed as a muscle relaxant. It's actually not very good for that, but it's related chemically to amitriptyline and is pretty good for fibromyalgia. Next. This stands for selective norepinephrine, sorry, adrenergic receptor. I thought it was uptake inhibitors, but duloxetine is also called Cymbalta. Milnacipran is called Savella. They're FDA approved for fibromyalgia, which means they work. It doesn't mean they work better than the other things. Next, pregabalin is also Lyrica. Similarly, it is, I believe it's FDA approved. Gabapentin is not, but that's has to do with gabapentin being an old drug off patent. So these are worth trying. Whether the side effects are going to be better, worse, similar to the benefit, you have to try and see. Most people most people will say in treating fibromyalgia, start with low doses and then increase gradually. I haven't found that necessarily to be the case, but that's the standard teaching among experts in the field. Start lower than you would maybe in other people. Next. Sorry, I didn't know that was in there. Next. So low-dose naltrexone is a drug that I know quite a bit about, not because I've studied it in fibromyalgia. There are 2 small trials I thought were quite interesting showing benefit. It goes through a loophole. Unfortunately, naltrexone is an FDA-approved drug at a much higher dose for trying to prevent opioid abuse, or for people who are recovering opioid addicts or alcoholics to sort of reduce the craving. But the low dose is not made by any standard drug company, so you have to have it made by a compounding pharmacy, and you have to pay more. So typically is up to $1 a day. And it's typically made in these low doses of 3 or 4.5 milligrams. And the thought of how it works is possibly at that little synapse that I showed you where the pain neuron comes into the spinal cord, is that instead of occupying the opioid receptor for very, very long periods of time, it's there for just a couple of hours and then off. And that basically sort of, just like I told you with exercise, if that works for you, it sort of gets the cells sensitized to our natural mechanisms for reducing pain, our natural feedback mechanisms that reduce pain. Next. No one really knows, so the SSRIs are drugs like fluoxetine or Prozac, whether they work as well as the SNRIs like duloxetine. Cannabinoids, it needs more study. It's hard to study at the moment. As you can imagine, the regulatory challenges are huge. Next. Non-steroidals, I do not work for fibromyalgia itself, but I think we often forget in rheumatology that patients with fibromyalgia are entitled to get the same kind of sprains and strains and that anybody else is. And non-steroidals could work for truly mechanical back pain, for osteoarthritis of the knee. And just like with trying to treat mental health disorders, that treating those might sort of help overall, especially if they help with sleep. Next, among the opioids, tramadol is somewhat helpful, probably because it isn't just a weak opioid, but because it does sort of mimic the SNRIs or SSRIs in some ways. Stronger opioids are a big problem, and not just because of the issues facing society, but it really was thought that they didn't work in fibromyalgia. And a lot of people ended up on very high doses because they never worked that well in the first place. And there's also a phenomenon called opioid-induced hyperalgesia, which is some people in general, the first time they're given opioids can have a paradoxical increase in pain rather than less. And that particularly happens at high doses. Next. And so I don't know a great deal about these electrotherapies. I can guarantee you other rheumatologists do not, but next. These are non-invasive. These are not things being stuck in you. Acupuncture, massage, a lot of patients do this. There's some data behind it, but not a lot. Chiropractic. I've never attempted this with patients. Next. Mindfulness training, probably always a good idea. Spiritual therapy, if that's part of your makeup. Next. I mentioned 2 specific forms of exercise that have had trials done, but it is thought that a lot of different regimens probably work for different people. Next. Anything someone wants to try with their diet, I'm all for it. Next. So I put this here not for you by any means, but for doctors, is that this the fact that people spend a lot of time and money trying to help with their condition, that's a pretty good sign that people are motivated to get better. And I hate to say it, sometimes when you focus on lose weight and get more exercise, and somebody comes back and said, I tried or whatever, and I didn't do it. And there's this idea of, well, they're just not trying hard enough. They must not be motivated to get better. And that's not only obviously on its face disrespectful, it's contrary. It's, really refuted by this list here. Next. Just a few things with myself. It all depends on what you are capable of doing in practice. So I've found with patients with fibromyalgia, I don't have many right now because I don't have a general rheumatology practice anymore, just at the VA. But I found that, seeing patient once a month, once every couple of months for short visits, I'm very grateful patients, even if I acknowledged them, I'm not sure you feel any better. I'm like, yeah, it's still useful. And rather than trying to cram a whole lot of discussion into a 20-minute visit where everybody leaves unsatisfied. I think doing something in the treatment realm is important rather than just saying, I'm sorry, there's nothing I can do for him. Just try to think of things, try to help, try to be supportive. And if you're doing something safe, then why not? I always tell people to try anything safe with their diet and your behavior. Just don't break the bank to do it. And there's certain things that I can do that aren't necessarily prescription medications that I think are safe and worth trying. Next. And then I say you don't search too hard. Don't MRI people from top to bottom, because you'll find things that aren't meaningful. But be aware of them. So, for example, if I have a patient who has a rotator cuff strain, they're going to do just as well with a steroid injection in their shoulder as anybody else is. And I think, automatically referring everybody to a psychiatrist is a little bit off-putting, or a lot off-putting. But if somebody needs it because they have hard to treat depression and anxiety, then it would be indicated. Next. Prognosis varies a lot. And so that's that 0 to 65% is not informative medically. It doesn't tell you much of anything about the condition. It tells you something about the studies and where they were done. But partial but significant improvement and improvement in functional ability and coping with getting through the day is what's very important. And patients need support in doing that. I don't need to tell you that. But I've said that multiple times, and I didn't create this presentation just for you, but to say this to doctors, that people need to know that that's an important component of the treatment of any medical condition, including fibromyalgia. Next, I think that's it.
Thank you so much, Paul. That was a great overview, and you covered a lot of information. And I truly appreciate your honesty in talking about the profession and care of patients. So I'd like to go now to Elizabeth and Vicki to hear their stories. These are two women who have fibromyalgia, and I'll begin with Elizabeth. Would you like to start telling us about your story?
Thank you so much, Pat, and everybody. My name is Elizabeth Alexander. I'm almost 58 years old. I grew up on a farm in Eastern Washington State. I do have a dog. You might hear her. Sorry about that. She does respond when I start to speak sometimes. I probably have had fibromyalgia since I was a child. I was diagnosed at the age of 24 after a very painful pregnancy. I developed cervical strain in my shoulder, and I went to see an orthopedic doctor, and they immediately sent me to a rheumatologist who immediately diagnosed me with fibromyalgia. I'm very lucky. This does not usually happen with most people. I was prescribed amitriptyline for sleep, and basically that was all the treatment I had. And that was fine to a degree. My fibromyalgia was fairly manageable. However, I happened to be somebody who was obese and became more severely obese, and it had a lot to do with pain. I developed pain in my feet and my knees. I had a hard time walking, and so my physical movement was very difficult. In 2006, I had gastric bypass surgery, and I lost 140 pounds from that, which helped a lot. When I went to go have the surgery, doctor said, of course, this is not going to cure your symptoms. And I'm like, I know, but it will help my mobility and whatnot. And it basically did. In the 1990s, I had several car accidents. And before I had gastric bypass surgery, I had a motorcycle accident. And those are the catalysts that made my fibromyalgia much more severe. And it took many years for me to recover. Two of the car accidents happened in 1 week of each other. And then I didn't have the motorcycle accident until around 2005 when I was in law school. And while I recovered fine, the bones recovered fine, it caused a disorientation in my body because I was compensating when I was walking. And so it had a lot of issues with that. And my fibromyalgia got worse. And then in 2018, my partner and I moved to Thailand, and I got very, very sick. And they don't know what caused the illness. Because of the gastric bypass surgery, it complicated whatever I had. I had some gastrointestinal illness. They sent test results to the CDC and the Mayo Clinic, but nobody could figure out what it was. And so I suffered from very severe malnutrition. I lost about 70 pounds in about 2 or 3 months. And I was just severely malnourished, protein deficient. I had a stroke, I had a heart attack, I had seizures. And previous to that illness, I had been severely over-medicated pain-wise. And because I'd suffered a lot of psychological issues due to my relationship, but also due to having fibromyalgia and suffering from pain, a psychiatrist put me on 2 benzodiazepines. So I was on tramadol, 2 benzodiazepines, oxycodone, Ambien for sleep, tramadol for sleep, Benadryl, and I don't know, a few other things. So I was severely over medicated, and it was wrong. And I went through, after I finished law school, I went to law school on all these medications, believe it or not. And I sufficiently did that. And I took the bar exam many times doing that. I never did pass the bar exam, but I came very close. So it wasn't the drugs that were keeping me from it, but it caused a severe lack of dysfunction in just my social and cognitive issues. I was living in a dream world for quite a while. And it took me many years to recover. But once I met my partner in 2015, even though I was still on the medications, we made the decision to move to Thailand. I was going to teach at a university down there. And I just became too sick, and I just about died from that illness. But the recovery has been difficult physically, but at least I have a lot of my cognitive abilities restored. My ability to emotionally deal with my life is much better now. So let's see, where am I? One of the things that happened because of the stroke and the other brain damage, I have some short-term memory loss. So I have to look at my notes here. Let's see. I have, my fibromyalgia causes these issues. I have interstitial cystitis. I have IBS. All of these conditions I had before this severe illness, but now I have peripheral neuropathy, and I have short-term memory loss. And I think the fibromyalgia may have an effect on my cognitive abilities. I don't believe I had any brain fog before that happened, other than being drugged to death. Because of all the physical disruptions, injuries in my life that have compounded my fibromyalgia, I am still on quite a bit of pain medication. I take a fairly low dose of an opioid. I take 25 milligrams of oxycodone in a 24-hour period, and I take gabapentin and Tylenol and ibuprofen every 4 hours. That's basically how my day is. I don't sleep very well. Right now, what I'm working on is thyroid. I have a severe amount of fatigue. About a year and a half ago, I was doing very well physically, but now my fatigue has increased exponentially. And while my thyroid tests come back normal, I've been reading a lot of literature that says that the conventional tests for thyroid aren't necessarily indicative of what is specific for the person, and that these standards may not specifically apply to an individual who has thyroid issues. So with my doctor, we're going to be addressing that. Also, I take a supplement called biotin, and that I've read affects false thyroid results. So that's kind of where I'm at with that. I'm fully disabled, and I have been for many, many years, even though I've tried very hard to finish my education. I have 3 undergraduate degrees and a law degree, and I went to culinary school about a year and a half ago. But I got injured, I injured my back, and my body just hit a wall. And since then, I've been really, really low on my physical ability. However, I go swimming 3 days a week. I'm in physical therapy once a week. I see an osteopath for back issues. And I feel like because I'm on Medicaid, I cannot get some of the services I need. I can't get massage therapy, but I did manage to get a manual physical therapist. They do some massage therapy, and that is included on my insurance. I can't see a chiropractor, but I can see an osteopath. So these are things people can sort of advocate for themselves. I have had some written conversations with Daniel Claw. I noticed that you referenced him, Dr. Monach, in your references, and I've talked to him about the drug. I don't know how to pronounce it, but it's the pharmaceutical version of GHB, which is a drug that has been known as a date rape drug. And it's been prohibited for wide dispersion. You can only get it from one pharmacy. And it's been shown in studies to really help people who have severe sleep problems. And I actually did write to him and asked him if he thought it would be efficacious for me to apply to the FDA for an individual compassionate use allowance for me to take it because of my severe sleep disruption. He said, there's no reason why you shouldn't. And so I wanted to pass that information on to people. My pain doctor has discussed frequently about the new evolving research in psychedelics, how they can help people with depression. And there's some theorizing, and I don't know if it's been shown in the studies, that it can help fibromyalgia. One of the reasons being is central sensitization is about the brain, and psychedelics can put you in a perspective of objectivity on what you're suffering from, and in some ways might reorient the neural pathways in your brain to bypass this central sensitization. So I'm not a doctor, I'm not a scientist. These are the things I've read about. You're welcome to do your own research on all of these topics. And Dr. Monach is nodding at me as I'm stating these things. I'm sure he's read about them as well. But I spend about 20 hours a week reading research because I want to get better, and I'm working very hard to get better. But the exhaustion, I can handle taking care of the pain most days, but the exhaustion is just dismantling my life, and the fatigue is overwhelming me. And I feel like if I can get the thyroid issue under control, then maybe I can do a little bit better with my life. So I guess that's really about all I say. I don't know if I spoke for 5 minutes or not, but.
Thank you, Elizabeth. Thank you for sharing that. And now I'll ask Vicki to tell your story.
Hello, my name is Vicki. My pronouns are she, her. I was diagnosed with fibromyalgia in about the winter of 2019. Like a lot of people, my severe symptoms were kicked off by a stressor. Again, my severe symptoms. I got sick in October of 2018 with the flu-like virus. And instead of healing, my body attacked itself. The doctors that I had at the time described it as a ganglionopathy. So my body attacked the nerve cell bundles in my back. This was basically a mild version of Guillain-Barré syndrome. I received IV immunoglobulin treatment and I started to recover, but my recovery took a little bit longer than expected. And I was still struggling with joint pain, nerve pain in my back at that time, brain fog, trouble sleeping, and severe fatigue. So in June of 2019, my neurologist sent me to a rheumatologist to decide if it was rheumatoid arthritis or fibromyalgia. I suspected fibromyalgia as my mother has it, and we were experiencing similar symptoms. When rheumatoid arthritis was ruled out, the rheumatologist told me that he would treat me as if I had fibromyalgia, but wouldn't give me the diagnosis. He told me that losing weight and exercising would help my symptoms, and told me I just needed to keep increasing my daily walking by 1 minute each week. I was not able to stick to this schedule because of my fatigue and the pain, and as each day my abilities were different. I wasn't able to make much progress, and I felt very unheard. In the winter of 2019, I moved and was able to find a new rheumatologist. After simply telling my history and my symptoms, He told me that I more than met the criteria for fibromyalgia and gave me the diagnosis and gave me a pamphlet on to attend a lecture to it, actually from given by Dr. Claw. He also said that he couldn't treat me for fibromyalgia, my rheumatologist, as at that time it wasn't considered autoimmune or a rheumatic condition. So my care was handed over to my primary doctor and my neurologist, and they continued treating me. After the diagnosis and with treatment, I still suffer from the following symptoms: chronic pain of both bones and muscles and nerves, fatigue, trouble falling asleep, joint stiffness, allodynia, and a lot of brain fog. I thought this was all due to the fibromyalgia, but was confused by a few other symptoms I had, such as subluxations of specifically my hips and my shoulders, and a lot of digestive problems, and also why I didn't understand why I had some of these symptoms since my childhood, especially if that illness was supposed to be my stressor and starting point for the fibromyalgia. In the fall of 2021, I saw geneticists who diagnosed me with hypermobile Ehlers-Danlos syndrome. This diagnosis explained the symptoms from my childhood, and I describe it as the underlying symptoms that I would still be dealing with if I hadn't gotten ill and developed fibromyalgia. Looking back, I've had a few high stress events where symptoms like brain fog and cognitive problems, pain, and trouble sleeping have happened. The first time was my senior year of college in 2015. I struggled the most with brain fog, but luckily got through and graduated. 2 years later, in a graduate program, the memory problems and trouble sleeping were so bad that on top of a few other stressors that I couldn't control, I had to leave the program. I don't know if this was the beginning of fibromyalgia, but it was the first few times that I experienced those groups of symptoms together. Today, I describe my fibromyalgia as the escalation and flare-ups of the hypermobile Ehlers-Danlos symptoms. It's why some days I can do chores around the house, go for walks, do my hobbies, and other days I can barely leave the couch. I have not held a job since 2018 when I had the ganglionopathy. I've tried online graduate programs, but when I got my fibromyalgia diagnosis, I knew that this was my new life. I wasn't sure that I would be able to physically work the job upon graduation, so I left. Even with the accommodations and going part-time, it was a challenge just to do the assignments, let alone thinking of doing a full job. While I have sometimes experienced post-exercise malaise, it's not consistent for me. I would say that that's the hardest part of fibromyalgia for me, is the inconsistency. Why can I do something one day and not another? I just don't know. I'm still coming to terms with my new life with fibromyalgia, and I am lucky to have a very supportive husband and a good team of doctors that are willing to try different treatments with me. I'm still learning how to advocate for myself and learning to pace my energy. So some days I want a refund on my lemon of a body, but it's what I've got, and while it's not my fault, it is my responsibility. Thank you so much for listening to my story.
Thank you, Elizabeth and Vicki, for sharing your stories, and I'm sure our audience can relate to much of what you've experienced. We appreciate the challenges that you have in living with this illness. I'd like to also thank you for staying on to participate in the discussion. So we'll now turn to our question and answer portion of the presentation. And if you haven't already, please feel free to submit your questions in the chat and we'll go ahead. I'll start with one question that came up, and Dr. Monach, we've heard Elizabeth and Vicki mention how they have dealt with pain, but there is a question about many patients with fibromyalgia have severe pain, and if you have any other comments to present in terms of treating pain.
Yeah, I think most of the studies that are done in fibromyalgia, pain is the main outcome. And of course, that's only part of function. And as both of you have mentioned, the fatigue is often the most debilitating. And that's one thing that, well, you just need to get more sleep, or, well, everyone feels tired. There's a difference between tired and, severe fatigue. The things I put up there, both in pharmacologic and non-pharmacologic approaches, I saw people put things in the chat of, I tried this, it worked. I tried this, it really didn't work, sometimes with the same treatment, things that were not on my list. And a lot of people end up doing that. So there is no really solution to the problem of pain. I think the key things that have become clear over a period of time is that strong opioids are almost always a bad idea to start people on unless they're absolutely necessary for some other reason. And then also for your doctors to realize that you could have another source of pain. So I actually responded to someone else in the chat that is actually known from people who've studied osteoarthritis and rheumatoid arthritis, that patients who have those conditions will describe more pain if they also have fibromyalgia than people who don't. And actually, it's hard to sort of be in remission for rheumatoid arthritis if you have severe fibromyalgia, because you always say your overall quality of life is, at most 7 on a scale of 0 to 10. And the level of pain will always be higher. And that makes sense, but until it was actually shown by research, it wasn't known. So I think that we don't want to over-treat people by saying we're going to get rid of all of your pain, but look for other causes. Just like I said with the shoulder injection, if somebody needs it. So some people, non-steroidals, ibuprofen, naproxen might not help for fibromyalgia, but it might help with some other part of you that is sore, and that might help you get slightly better sleep and help with the fibromyalgia. So I don't know if that answered the question or not, but I'd say the multimodal approach, what we probably really need in this country is for a lot more places to have multidisciplinary groups that have that say this is a patient, like sort of meeting together, this patient needs these specialties, and they need, this person needs to be a TENS unit, this person needs supervised exercise, this person needs cognitive behavioral therapy, this person doesn't need exercise, things like that. And we at this point aren't equipped to do it, but that's what's really needed, I think.
And so needed for patients with ME, CFS. I know our group has talked a lot about our hopes of someday having a multidisciplinary clinical center to provide care. There is a question about a blood test that has been proposed for helping to diagnose fibromyalgia that seems to be available, and there's a question in terms of whether you've heard of this, Paul, or do you have an opinion?
The only way in which I have heard of a blood test being done was a patient at the VA who brought me his genetic risk score. So I don't know if that is what is intended or not. A genetic risk score is merely what it is, but that's actually true for a lot of tests we have. Nothing is perfect. And more importantly, clinically, that's what he had. Although interestingly, he'd been treated for many years as having psoriatic arthritis because he had psoriasis. And he's like, none of the drugs work. All that stuff that shows, Phil Mickelson winning majors didn't help me at all. And that's because that really wasn't the source of his pain. So that kind of thing, genetic risk scores are probably going to make their way into clinical medicine, if that's what we're talking about, eventually, but they're always going to be relatively small changes. And so they're more helpful when you're not sure diagnostically, or if they identify subsets to say, okay, this is somebody who also has something else, and we should take a different approach of sort of dividing up the syndrome into its different causes that you would treat differently. I'm not aware of any other blood tests, but like I said, this isn't an area of my specialty. So interesting that I put in Dan Claus, the leader within US Rheumatology, and that both of you have actually encountered him separately, but definitely his articles and one of the other ones I put in there are really the highest quality summaries for clinicians that I know of. So it's good to know also he's involved in the communication with patients as well.
But somebody added in the chat that there's an immune profile test showing that there's a characteristic profile in fibromyalgia.
Okay, yeah, I'm not aware of it, and I'm not sure. Just thinking as a scientist what the control group was, but I wouldn't be surprised. I mean, these are and it takes a long time for things to get from like the bench to research to actual clinical use, especially for all the research that's been done with sort of panels and what are called biomarkers that aren't just one blood test. it hasn't made its way into clinical practice because it's not the way laboratory medicine has traditionally done things. We need to get there.
There's also a question, Dr. Monach, whether fibromyalgia can occur in children.
Yeah, absolutely. And so it is sort of a saying, and I don't actually mean this in the way I said of doctors being dismissive of it. Among pediatric rheumatologists, it's more of a commentary on how little pain sometimes juvenile rheumatoid arthritis causes in kids, that parents will just notice their kid like can't get out of the car, it's, you know, limping down the stairs, something like that. They said if a young person is sent to a pediatric rheumatologist primarily for pain, it's more likely to be fibromyalgia. There is an association with hypermobility, just as Vicky mentioned. There's no question an association, both early in life, you know, onset early in life and also later in life. How much it predisposes to early osteoarthritis, that's more of an unknown. Is it a mimic of fibromyalgia? Is it a risk factor for fibromyalgia? Well, if it's pure hypermobility that is causing stretching of joints, that shouldn't cause fatigue as well. So, but there's definitely an association with people sort of meeting the overall picture of fibromyalgia and joint hypermobility, whether it's EDS or doesn't have a gene associated with it. But yeah, and that is often something that is seen in pediatric population as well. I don't know how common it is, but it's not as common as in adult rheumatology, but they still, a pediatric rheumatology practice of the new referrals coming in, a sizable percentage would have joint hypermobility or fibromyalgia as the sort of diagnosis of choice. It's just, it hasn't been studied as much as kids, and so people are a little more reluctant to use the term.
Thank you. And one final question, this era of COVID, do you think studies from long COVID or ME/CFS could be relevant to fibromyalgia as well?
Yeah, I mean, definitely when you see differences between CFS, and fibromyalgia, you wonder if there's sort of a study bias. So definitely there's been more study of the immune system and of inflammation and in ME, but to the extent that there has been study in fibromyalgia, it hasn't been as consistent or dramatic of findings. And I do think that the issue with exercise, I've had patients with fibromyalgia who say, I can't tolerate exercise. And I wonder how many times have I sort of missed it. I don't push people to do things they can't do, but I have heard more than oh, it hurts while I do it, that's why I couldn't increase my exercise, versus if I exercise, I can't function for a day. Okay, that's not something I was ever taught in medical school. It's familiar to all of you. So that was eye-opening to me, and sort of how many times have I missed this in patients I was seeing for fibromyalgia. Sorry, so in terms of the different studies being done, I think they're definitely, we have too many silos, and the multidisciplinary approach would be if it's linked to research, would be a way of looking at these different conditions sort of as either those overlapping Venn diagrams that I couldn't draw, or as a continuum. And if of trying to put some rationality behind, is it inflammatory or isn't? Well, probably is in some people and not in others. And how do you pick apart what's important in different people? But I think the different research techniques that have proved to be valuable in one condition should probably be looked at in other conditions to see if the same findings are made, if that makes sense. That's sort of low-hanging fruit.
Thank you. Well, we know you're giving a grand round soon, Dr. Monach, and we would appreciate you making the distinction about exercise in people with fibromyalgia and ME/CFS and who may have comorbidities. We're trying to make the providers more aware of that in terms of the dangers of doing exercise in that group. Well, thank you so much, Elizabeth and Vicki and Dr. Monach. This has just been great. We really appreciate it. The recording of this session will be posted on the Mass ME/CFS YouTube channel in a few days, so watch for your email about that. The topic for our Sunday conversation in June is a whole person health approach to myalgic encephalomyelitis, chronic fatigue syndrome, lessons for post-COVID conditions. The date is June 19th at 4 p.m. Eastern Time. And the featured speaker is Dr. Maria Vera Nunes, who has been specializing in the treatment of people living with ME/CFS for more than 20 years, and who originally worked with Dr. Nancy Klimas at Nova Southeastern University Institute for Neuroimmune Medicine for 7 years. This program is being presented jointly with the New Jersey ME/CFS Association. So please join us. And if you have any ideas for future programs or speakers, please email events@massmecfs.org. Sunday Conversations is not intended to be a series of research presentations, but rather programs that will provide a variety of practical information that patients and families both need and want. And if you'd like to join the Sunday Conversation team, please email volunteer@massmecfs.org. We're working on the fall schedule now, so please let us know. And finally, if you have found this program worthwhile, there are a few ways you can help. You can make a donation to help support this series by donating online at massmecfs.org/donate. And on the same page, you can sign up for our newsletter. And if you donate $25 or more and check the Become a Member option, that will establish or renew your membership, and you will be invited to our members only programs. Thank you all for coming, and we hope to see you again next month.